Hello, everyone. Let me get my computer down a little bit. All right, we are in week 9, but I did want to go over one of the questions from last week, and I want to kind of work with it together with y'all. Okay. Now, this question is asking what happens when a medical device malfunctions, um, whether or not a patient is injured. Okay. The first thing I want you to notice is what the question is focusing on. It's focusing on the device itself. OSHA is concerned primarily with worker safety. The EPA focuses on environmental concerns. Who develops global health guidance? So, WHO, the World Health Organization, not who, but okay. Now, the FDA, however, is really the agency that is responsible for kind of like regulating medical devices in the United States. Because of that responsibility, medical device malfunctions are reported through FDA reporting systems so that the agency can kind of like monitor what's going on with them, identify different trends, and determine if recalls or corrective actions are needed. So, a helpful exam tip is to ask yourself, what is the main issue in the question? If the issue is safety or performance or malfunction of a medical device, your mind should be kind of thinking of where to go, right? Now, quick memory hook, okay? Device equals FDA. Worker safety equals OSHA. Environment equals EPA. And global health guidance equals WHO, the World Health Organization. Okay. For a fact, let me put this in the, yes, you are on the right thinking. Let me put this in the chat for y'all. So it's like the quick memory hook, just in case, hint, hint, questions do come up on the cumulative exam. You guys will have it. Like if another question comes up, you're going to be thinking, okay, wait, is this talking about a device? Is it talking about the worker it's themselves? Are we looking at the environment, or is this like global? Are they talking about some type of pandemic going on? Okay. Also, I want you to be thinking about like why the device would still be reported even if no patient injury occurred. Okay. That's another way to kind of look at these different things. Okay. So, excellent question. So, the question that was asked was, why would you not choose FDA if it talks about the medical device? Okay. And then there's another question too. I want to make sure. Let me save that one as well. Okay. So when we're talking about answering anything for us, okay, FDA talks about medical devices, but does not automatically make the FDA the correct answer. And I'm going to kind of break it down. And that's an excellent question. We go back to this question, okay? A medical device that malfunctions with or without patient injury, should it be reported or should it be removed from service and reported to which agency? Okay. So again, if it asks who regulates, approves, or monitors medical devices, then the FDA is going to often be the correct answer. So you're asking the right question. But if it asks who accredits healthcare organizations, the answer would be something like the Joint Commissions. If it asks who develops sterilization standards, then the AAMI. So why OSHA? If it asks who sets workplace safety standards, so in here, you're looking at the keyword right here, they bring up patient injury. So now think about now a person could be potentially involved. Patient, but it could also be a worker. It could be the surgeon. It could be the anesthesia. I moved my mouse. This one or two words right here changes what the question is asking. Okay? The FDA's primary role, approving, regulating medical devices, approving, regulating, okay? Monitoring, looking at different recalls, evaluating. Many organizations kind of discuss different guidelines. The exam, especially cumulative coming up, often tests whether you know primary responsibilities of kind of each organization. So you're asking the right questions, okay? But bring it in, talking about some type of injury with or without. Now we're looking at, okay, this particular item could potentially cause harm to now humans beyond just the medical device itself. Does that make sense? Because you may kind of see a concept come up, and I want y'all to be very comfortable kind of being able to pick that out. Okay, so if you do have questions about a quiz, yes, you can definitely send it to me. And if it is marked incorrectly, let me know and I will fix that as soon as possible. So that's for everyone. If like you did mark the right answer and for some reason the computer just didn't like click it or whatever, let me know as soon as possible. And I will kind of go back. It doesn't matter what week. You guys can go back all the way to week 1. If that's what happened, let me know so that I can kind of update that and get you your correct scores. Okay. All right. Now, tonight's a little tough. Okay. So I want you to take a breath with me for a moment. We're shifting slightly. Okay. Yes, we're still practicing and preparing for our cumulative exam and what to come. We know that we are 2 weeks out, right? But today is about something just a little bit deeper. Now we're talking about professional judgment and the human experience. As STs, we're not just setting up trays, okay? We're not just anticipating instruments. You guys are stepping into moments that are often life altering for patients and their families. Psychosocial needs and end of life care are not extra topics, they are part of professional readiness. Now, you guys already have the foundation. Now we're just sharpening our judgment. The cumulative exam isn't about trick questions. I know sometimes it feels that way. But it's about whether you can kind of think just like a CST. This week, concepts, chapters 5, chapters 14, communication, ethical responsibility, and the human dimension of surgical care is what we're covering. As we move through today's session, I want you to think about how these concepts show up in the operating room environment. So let's start with our quote of the week. Keep your face always towards the sun, and shadows will fall behind you. 2 weeks before the cumulative exam, it's easy to focus on shadows. What do I mean? What if I forget something? What if I don't pass? What if I'm not ready? That's shadow thinking, and it's normal. But sunshine in the context is your preparation, it's your discipline, it's steady review, it's showing up even when you are unsure. When you focus on what you can control, reviewing objectives, practicing critical thinking, asking questions, the anxiety naturally will move behind you. Does not disappear, it just stops leading. In the OR, there will be moments of pressure. You cannot control every variable, but you can control your preparation, your composure, your response. That is your professional judgment. That is what you're building right now. On a scale of 1 to 5, how mentally steady do you feel about the cumulative exam right now? No judgment, just how do you feel personally? Now keep that number with you. Whether you're on that scale, that's information, not a verdict. If you were mentally saying you're at a 2 or a 3, good. Now we know where to focus. If you're at a 4 or 5, maintain that momentum. No one is allowed to spiral silently, okay? We are here for you. You've completed 8 weeks in this course. You're not starting from zero. You're refining. And tonight we're going to continue, okay? Let's get into some integration. All right. As we get closer to this cumulative exam, you'll notice that the questions are no longer, do I know this term, right? It becomes, can I apply the knowledge in a real operating room with real people? In this space, what is shared here stays here. We are going to be discussing very sensitive topics this evening: fear, end of life situations, ethical dilemmas. I want y'all to be respectful of each other. It will be much harder in a clinical setting if you can, okay? We're going to be talking about culture, fear, again, grief, sometimes uncomfortable realities. I'm going to share with you some experiences that I have had. You may not agree with everyone's perspective, okay? But you do have to remain professional. And I bring that up because in the operating room, patients don't come with identical beliefs. Our role is not to judge them. Our role is to kind of support surgical care with integrity. Now, growth in this profession often happens when there is not a perfect answer. End of life situations rarely feel neat. And when I share, you'll know exactly what I mean. Professional judgment means making the most ethical, patient-centered decision you can, even when it's complex. As we approach the final exam, I want you to be thinking about how your technical knowledge supports your ability to be compassionate. If you understand the procedure, the sterile field, the sequence of events, what does that free you up to do? It frees you up to notice the patient's anxiety, observe the family dynamics, stay calm in high emotion situations. Competence creates space for compassion. Silently to yourself, and tonight, because of how thick the conversation is, I'm going to be asking you to think a lot silently to yourselves, okay? So, when you feel technically prepared, you're better to answer to yourself, okay? You're not just preparing to pass an exam. You're preparing to carry yourself well in moments that matter. That requires both skill and humanity. Chapter 5 reminds us that psychosocial needs do not disappear in the operating room. They just become quieter. And sometimes silence is not calm. A patient is unusually quiet during transport and positioning. They're gripping the sheets, they're white knuckled, they're tense. Nothing dramatic. There's no crying. There's no verbal complaints. But something is happening. This is where your professional judgment begins. So we look at Maslow's integration. Think about which needs might be threatened here. When safety, for example, feels compromised, physically or emotionally, the body responds. Silence can be that coping mechanism. So how do we distinguish between a patient who is calm and one who is paralyzed by fear? So there's things we're looking for: muscle tension, their eye movement, their breathing pattern. I mentioned them gripping the sheets really tight, right? Maybe they won't even look at you. In the OR, nonverbal communication is often way louder than any words spoken. If you're technically focused but not observant, you can miss those little things. So, as STs, we may not be the primary communicator with our patients, right? But we are always observing. Our awareness supports the entire team. If something feels off, that intuition matters. It does not matter if you are the brand new student in the room. You have emotions, you have eyes, you can see. Okay? Technical skills allows us to function. Situation awareness allows us to lead. And leadership in the operating room often starts with noticing what others overlook. Now, we have professional response to avoid and therapeutic response that is preferred. I'm making sure you don't escape. Sometimes the patients may feel like, what's going on, right? And the bed is narrow, right? So this reminds you to stay centered so you are safe. As a patient, which one would you prefer? The left or the right? That was just kind of quick to kind of think about. Okay, now we're moving into the cultural competence, spiritual needs. This is where things can feel complex. In healthcare, personal beliefs do not disappear at the door. Patients bring their faith, their culture, their rituals, and meaning systems with them. So, a patient refused to remove a religious icon or jewelry until the very last second before induction. That's not defiance, that's significance. Our responsibility is kind of like a twofold here. One, we respect the patient's belief, and two, we maintain surgical safety standards. Cultural competence is not ignoring policy, it's navigating policy with awareness. So, is cultural competency a safety skill? What do you guys think? So, I have a couple mixes. Yes, no. No wrong answer. Just wanted to kind of see where you're thinking. Okay? When patients feel respected, cooperation improves. When they feel dismissed, resistance increases. Safety is in relation just as important as much as it is procedural. Okay. Another thing to think about is clarifying the scope. If a patient is reluctant, the appropriate step is not to confront them and be like, why don't you understand this? It's explanation. Explain the risks, burns, loss, contamination. Offer a safety alternative, such as immediately handing the item to a designated family member. That maintains dignity and policy. Now, if you were a patient and that item represented your faith, again, this is one I want you to think to yourselves. What would you need to hear to feel respected? As you were thinking, was it the tone? Was it explanation? Or was it reassurance? I ask that because that's that professional maturity. What would you want to hear? We are not responsible for changing someone's beliefs. We are responsible for maintaining safety while honoring humanity. That balance itself is what makes this profession both technical and ethical. You guys with me so far? Okay. Now, this is where we kind of get into a transition that you may witness in the operating room. A trauma case begins with a survival focus. Every movement is urgent, every decision is fast. And then sometimes the focus shifts. A couple years ago, We were in the operating room. You guys know I work evening shifts. So we get a call around like 10 o'clock that we get a case coming into the operating room, and the surgeon is completely transparent. He's a general trauma surgeon, and he's like, not really sure about this case. And so we're like, okay, it's going to be a trauma. We're going to get everything ready. We get two teams set up. Unknown to us, they were working on the patient as the patient was coming into the operating room, right? So if you don't know what I mean by working, there was already chest compressions being done. Patient gets into the room and we're like moving. Okay. Both teams were working, abdomen's distended, blood's going in. We're working 45 minutes and the case is called. Now, in our particular case, it did not transition. In some cases, it does transition to organ retrieval. The shift changes the energy in the room. Okay. For ours, we stopped. Working at a children's hospital, you realize that our patient was 4. Not that that changes the situation in the fact that we lost the patient, but it hits you. Okay. There are other cases where you're still working and the family has made the decision to now allow their organs to be retrieved and given to someone else. In our case, we already had an idea that that was probably going to be the outcome because the surgeon was very transparent. And later we found the details of what really had happened. Okay. But it does not change that the energy in the room does shift. Urgency often becomes quiet precision. The emotional tone shifts from rescue to now preservation. And as professionals, we have to adjust with it. So let's ground this technically, okay? The chapter talks about a heart-beating cadaver and a non-heart-beating cadaver. Heart-beating cadaver, the brain is declared dead. Circulation is maintained like by a ventilator. Organs are remaining perfused, so circulation is still going through the body. A non-heart beating cadaver, circulation has ceased. Retrieval timing is critical due to tissue viability. Again, working evenings. We get a call that we're waiting. Having been in a heart beating cadaver and a non-heart beating cadaver case, they are treated a lot differently as well. For the heart beating cadaver case, there is time, like you're not necessarily rushing, the body's perfusing. In the heart beating cadaver case, we literally get a call and we have to wait for the patient to expire. And I hate using that word, but and then we have literally an hour from the time they are in the room. Keep in mind, they're with their families. There is a member with them that escorts them to the operating room, stays in the operating room with us and helps us close the patient back up for dignity, and then escorts the patient back with the family as well. But the timing is a lot differently because time is of the essence. You have literally an hour to chill that body down before you can even procure the organs. Understanding that distinction is exam relevant, right? But it's also ethically significant. Heart beating cadaver, non-heart beating cadaver. Regardless of the procedural shift, the core principle remains the same. We treat the body with the same respect regardless of the outcome. That does not change. Our professionalism must not fluctuate with the prognosis. So again, a question for you to think about. If you were in that room during a transition, meaning you're in a case and now all of a sudden we have switched from Reserving to preserving. Okay? What would help you stay professionally grounded? As you're thinking to yourself, you may notice that you're saying mentally, maybe composure, respect, focusing on one role, clarity. You may not control the outcome, but you do control your conduct. And end of life care conduct matters. Are you guys with me so far? Okay. So we often learn the stages of grief as a clean sequence: denial, anger, bargaining, depression, acceptance. But in real life, especially in healthcare, it is not linear. It's messy. And it doesn't only apply to patients. These stages show up in families. They show up in us as team members. I'll be completely transparent. I am a compartmentalist, meaning because I tend to work evening shifts, I will package what was going on, stick it in a room, lock the door, and usually after my case, I decompress. Everyone handles things differently. Okay. I don't know if it's the military or what, but that's how I operate. Okay. There's also a family dynamic that we talked about. If you mentioned, when I mentioned the non-beating cadaver, I mentioned that there's an individual with the family members as they're saying their goodbyes, as they are making the very tough choice to do the line, right? Where they have their loved one and they're walking to the operating room for their loved one to bless other individuals. Okay. But that doesn't mean that they won't be angry. Angry may show up in the waiting room, frustration towards us, blame, impatience, repeating questions. Anger is often fear with nowhere to go. When you understand that, you try not, because we're human, to absorb it personally. Let's think about us as a team. After an unexpected outcome, you may see bargaining. If we had just, maybe if we had tried, or even quiet withdrawal, which may reflect depression. This is human. Healthcare professionals, we are not immune to grief. We handle it in different ways, but we're not immune to it. Anger is often a defense mechanism. It is rarely a personal attack, even if it feels like one in the moment. When we talk about professional maturity, that means responding with steadiness, not reactivity. Now, I want you to think about how you stay grounded when someone around you is emotional. Do you put up boundaries? Do you practice breathing? Do you try to listen a little bit closer to what they're saying to actually hear the meaning? How do you maintain, or how will you maintain, that professionalism? I say that because grounded professionals stabilize environments. We cannot control how others process grief, but we can control our composure. And composure in high emotion moments is a hallmark of real professional judgment. Now, this is often the quietest part of a surgical care. There's no urgency, there's no instrument exchange, but it is one of the most important professional and, in my opinion, humbling responsibilities that we have. And that's postmortem care. It is still patient care. When death is expected and it's not under investigation, preparation focuses on dignity. We're cleaning the body, we're removing drapes appropriately, we're organizing the room, we are preparing someone to be seen by their family. That matters. But before anything is removed, we pause. Why? We have to ask, is this a coroner's case? This is not optional. If death happened in the operating room, or there was an unwitnessed death or suspected criminal activity, we stop. We do not remove tubes. We do not clean sites. We preserve evidence. This is legal protection for the patient, for the family, and the institution. Why is distinguishing this status a legal necessity? I want you to be thinking of chain of custody, evidence integrity, legal accountability, and professional liability. Good intentions do not override legal standards. I also want you to think that dignity and legality can coexist. We have to know when compassion looks like cleaning, when compassion looks like preserving. That distinction defines professional judgment. Okay. So the question, will death, suspected criminal activity be in the file, or would we know? It depends on, and that's an excellent question. It depends on what the file or record we're looking at. Like, you'll definitely know. Okay. I'll take it to the military. So we had a patient, and certain people were with them to let us know that, okay, this is definitely a case that's going to the coroner. Bullets, different things were gathered for evidence. Depends on a lot of the circumstances that was found. 9 times out of 10, when they come to the operating room, we're going to definitely know. Okay. There will be very telltale signs. It won't be one of those like, oops, we weren't supposed to, or you know what I mean? Like, you'll definitely, without a doubt, know when they come. When we do our timeout, for example, which we'll talk about in mod 3, those certain things we know for a fact. Also, when you see officers standing outside the operating room, 9 times out of 10, you'll kind of be like, okay, we know this is a little bit more than just a regular, postmortem case or etc. Will be questioned after if the patient has passed you should not, that is not one of the, and that's a great question. So the question is, will we be questioned after if the patient had passed in a suspected criminal activity? I have not seen any concepts on the final or this week that are that specific in nature. It'll be more, do you understand what happens postmortally in respect to taking care of the patient, dignity, different things like that. But you may also get concepts. Let me correct that. You may also get concepts understanding when a case goes to the coroner's versus being able to kind of just break down the room normally. So knowing and understanding a coroner's case and when the patient would be considered is a concept that may come up, because again, they're randomized. So, but that specificity, I have not seen a concept like that. Would it be put in the operative notes? It would be in, not the operative notes, because the operative notes are going to be just what we did. It would be on the notes as we're coming in, or nurse turnover. So like ED nurse, most likely the ED nurse coming into the operating room. Now, if the patient, no, it wouldn't be the operative notes, because operative notes is only what we do to the patient. It'd be kind of like the ED nurse to the operative nurse, and then word of mouth, they would tell, like, again, you'll have telltale signs, but the interoperative circulator to the PACU circulator, it wouldn't be in our specific notes, if that makes sense. But excellent questions. And with that, this is why that distinction defines how we act, how we move, how we respect our patients. Okay? Now, this is one of the hardest moments you may encounter. Trust me. Okay? And you may go through your entire career without having experienced that. And that's excellent too. Okay? But it also going to depend on what shift, where you work, the hospital. So let's say a patient has expired. The family looks at you and asks, did they suffer? What happened? Pause. In that moment, your human instinct may want to explain, to comfort, to fill in the silence. That impulse is normal, but professionalism requires clarity. There is a difference between empathy and over involvement. Empathy does connect, over involvement crosses our scope. We are not the diagnosing provider. We are not the spokesperson for the clinical outcome. So the appropriate response, I am sorry for your loss. The surgeon will speak with you shortly. But notice what that does. It acknowledges pain. It does not speculate. It does not kind of like interpret for our patients. It does not provide medical explanation. So in the chat, why would offering explanation, even if you were present, violate our scope? Misinformation can unintentionally be given. As a CST, we will be interacting with the family. Oh, so both. The question is, as a CST, will be interacting with the family or surgeon? Both. Depends on the situation. There are often times when you are a runner and or you are kind of free for the moment and they'll say, hey, Scarlett, can you walk this family back to Holden? Even in that brief 2 to 5 minute walk from the operating room back to the holding area, you're there with the patient. A lot of times we are definitely with the surgeon, right? We are right there side by side across from in the operating room in the thick of it. Okay. But we still kind of stay in our lane, stay in our scope, giving them the wrong information, right? It's out of our scope of practice. Excellent. Exactly. We are not licensed to give medical advice or give that to the patient or their family members. It's a legal risk, right? Sometimes we could be giving them incomplete information. We could be undermining our surgeon's role. And then there's that liability, unfortunately. Even accurate information delivered outside of scope can create harm. As CSTs, we provide presence and silence. Sometimes the most professional thing that we can do is say very little. Now, here's the reality. You're going to finish a trauma case. 20 minutes later, you're scrubbed in again. Trust me, I know. That very first case I shared with, that was my first case of the evening. I was preparing for the case. I was working 3 to 11. This case happened around 5 o'clock in the evening. And later we had found out what transpired. It was a full car. And if you are in SoCal, you probably have heard of the situation because it was all over the news. And it was multiple individuals in the vehicle. Couple were DOA. When the EMTs arrived, they had already passed. One individual went to like Sharp, and then two came to us to the children's hospital. Okay. But that was my first case of the evening. I say that because the world did not pause for us. Our nervous system was still processing, but we still had the rest of the shift to do. We are trained to function under pressure, especially in the operating room. But functioning is not the same as processing. If we ignore that difference long term, burnout does follow. Emotional resilience is not about being numb, right? It's about being regulated. In that moment, you focus on the task. That's appropriate. That is survival level professionalism. But then there's a post shift, a debriefing. This is where teams kind of struggle, right? Where debriefing allows the experience to be processed rather than buried or thrown in a room and locked. It moves the event from emotional intensity to structured reflection. That protects the team. That protects you. And then there's long-term self-care. Self-care is not an indulgence. It's acknowledging limits. You cannot carry every outcome without consequence. We as professional CSTs who last in this field, we know when to pause. Debriefing is so important for team safety because it prevents repeated errors. It helps clarify communication breakdowns, identifying system gaps, improving future responses. It also reduces emotional spillover in the next case. Debriefing improves performance. It strengthens trust. It enhances safety. So, for your exam, right? You're not going to be tested on emotional storytelling. I add that in to kind of help connect the dots. You're going to be tested on applied thinking. Maslow, for example. On the exam, you may see a behavior, agitation, aggression, silence, withdrawal. The question is not what is Maslow? The question is which need is threatened? Can you connect behavior to psychological, to safety, love, belonging, esteem, or actualization? If you can link behavior to need, you can answer those appropriately. There's also some legal ethical from this week, understanding the distinctions. I have definitely seen where they throw a scenario and they're like, is this, let's say, an advanced directive issue, DNR, DNAR? These are not interchangeable terms. Know who initiates them. Know what they authorize. Know how they affect interoperative care. Clarity here prevents legal confusion. There's also concepts on cultural issues, handling amputated limbs. There is a certain way that we do. Religious prohibitions, blood products. Definitely questions and concepts on that. These questions often are going to test whether you understand both policy and respect. Safety does not cancel cultural awareness. It integrates with it. Try not to kind of memorize these in isolation. So when you study, imagine a patient scenario. Picture the operating room. Ask yourself, what would this look like in real life? If you can visualize it, you can reason through it. So let's say a patient becomes verbally aggressive during transport. I want you to be thinking which Maslow level is most likely threatened. What makes that level more likely than others? We're 2 weeks away. I don't want you guys to panic. We are 2 weeks away from demonstration. You already have the framework. Now we're really just kind of refining our reasoning. Remember, our quizzes, they were just showing us our gaps, where we need to hone in, where we need to study, so that when we get to this cumulative exam, we've gathered all those gaps, closed them, and we're able to reason through those certain questions on the cumulative exam. Now, I know I did a lot of talking this evening because I knew the subject was tough. Okay. And I really appreciate you kind of sticking it with me. For those of you that are watching this playback, how can a patient's cultural belief affect their end of life care? When a patient can express their wishes, what should guide decisions about organ donation? And how can we as CSTs balance comfort and professionalism when caring for a dying patient? For those of you who are here, some of these questions that I asked those watching the archive will show up this week on your week 9 quiz. I want you guys to hear this. You are ready, not because you feel zero anxiety, but because you've done the work. Even if you feel you haven't, I'm telling you, you have. You've learned safety checks, legal boundaries, but now you've also studied the anatomy of the experience. Tonight, fear, grief, loss of control, cultural needs, ethical restraints. That's what separates mechanical skills from professional identity. As we get closer to the cumulative exam, I do not want you to shrink your preparation down to memorization. Think in scenarios, because the cumulative exam does bring out scenarios. Think in judgment, think in scope. The exam is simply asking, can you think like a CST? Okay. What kind of cases would you operate if it was already named a coroner's case? Um, Great question. Think of a trauma involving possible homicide. Is that, yeah, or near death from a possible or attempted homicide that unfortunately ended up as a homicide, right? Um, there are in the chapter, haha, there is a section on there that will give you specifics, and I'm glad you brought that up because that is what the quiz is going to pull from. That's where the cumulative exam is going to pull from. There is a section that specifically talks about those, and it's going to be an really good to be able to distinction if this particular question or if this particular scenario comes up and they're going to ask you certain things like who would be responsible for, or where would this patient go, or would you be able to? Okay. Is there anything that we can do for the patient if they pass? Meaning, specifically, does the operating room take a moment of time for them? Depends on the situation, and I'm not really sure what you mean is if they passed. Um, we are going to definitely present them in a certain way depending on the case, depending on if it's a coroner's case. There are some cases where we have to leave the body in the room. There's some cases where if there's no staff there, we move the body to PACU and one of us will sit with the body until individuals can come. Okay. Great question. Okay. Preparing them for the families. So again, it's going to depend on whether it's a coroner's case, because if it's a coroner's case, we do not remove tubes. We do not remove anything. We just kind of like, pull the sheets back up or whatever. If it's not a coroner's case and we are able to kind of do things, yes, we can prepare the body. For example, for my, patient that was a non-beating cadaver, the tech that came with, we actually kind of closed the body and we got the body ready, presented it for viewing for the family. So most definitely we do have that. It is in our scope. Okay. Again, it's also going to be on the facility that you are attached to, that you're working with, and they'll have the details in their policies of what, we can do. But most definitely, in my experience, being that I have been able to, yes. for a non-coroner's case? Great question. Any other questions? Now, if something does come up again, this is a tough week, the 2 chapters. Do not hesitate to reach out and ask me to break it down. Um, that is what we're here for, okay? I do want you guys to have a wonderful rest of your evening. We have micro for everyone who can attend. I am looking forward to meeting with you guys. Okay. Again, because this was such a tough subject, at least because I put myself in those back to those cases, but it is a tough subject. Um, do take time for yourselves as well. I know we harp on studying, breaking this down, doing that, but it is just as important for your mental that you do take a time, take a moment for yourself. I want you all to sit back and look at where you can, what you have done in the last 8 weeks. Okay. Look at the amount of information that you've gained, the amount of information that you can now teach back, even though you may not feel as comfortable or confident. I'm telling you that you're able to do it. Things that you weren't able to do week 1, module 1. Okay. Celebrate the wins. So that's going to help carry you as we get closer and closer to the cumulative exam. All right. I'm going to get off my soapbox. And I do want you guys all to have a wonderful, wonderful rest of your evening. And I do look forward to seeing everyone who can attend tomorrow's live session. Good night, everybody.